Hi, my name is Ashley Prendergast, and today I'll be discussing my clinical case study on a patient with diabetic gastroparesis. So I'll go over a little bit about the patient's information and his history, the pathophysiology of type 2 diabetes and gastroparesis, the hospital course of action that the patient received versus the evidence-based practice guidelines, as well as some of my recommendations for future. The patient I saw was a 53-year-old male who was admitted on September 9th of this year. He weighed 199 pounds and was 6 feet 3 inches tall, and this placed him in the healthy weight classification on the BMI scale. The patient was admitted for nausea, irritable vomiting, and severe abdominal pain. In 2006, the patient was diagnosed with type 2 diabetes, and shortly after that he was placed on insulin. As a truck driver for over 30 years, his CDL license was revoked once he was placed on insulin, and so as he said, he went out of control with all aspects of his life, including his diet and medication use. And in 2011, he was diagnosed with diabetic neuropathy. In his feet, he had a lot of pain. He still has a lot of trouble getting around, even walking short distances. And this was kind of a wake-up call for him, so he decided to get his life back together. He started following a carbohydrate-consistent diet, taking his meds as he was instructed by his doctor, going to his doctor yearly for checkups and such, but the damage was, so to say, already done. In late 2014, the patient started experiencing nausea, severe abdominal pain, vomiting after eating that would last days, and in 2015 he was diagnosed with diabetic gastroparesis, and he was hospitalized 3 times after the initial diagnosis, and this was his 4th follow-up admission. And the patient stated that he had no previous food or nutrition related education relating to his condition at all, and because of this he lost 75 pounds since the initial diagnosis in January. So in 8 months he lost 75 pounds because he couldn't eat and had the symptoms of nausea and vomiting. A little bit about type 2 diabetes. There's 2 major problems. First off, there's an insulin deficiency, so the pancreas is not producing as much insulin as it once did, as well as insulin resistance, so the cells of our body, the adipose tissues, muscle tissues, are more resistant to insulin action, requiring even more insulin than used to be needed for the same result. And these 2 coupled together results in higher than normal blood sugar levels, and our cells are left without the needed energy. And so the cells will send a signal that they need energy, and so the liver will release its stored form of glucose into the bloodstream, raising the blood sugar levels even higher, and prolonged hyperglycemia or large swings in the blood glucose levels can result in some of the complications like the neuropathy or gastroparesis. So in gastroparesis is the slowed or delayed emptying of stomach contents. And in gastroparesis, the vagal nerve, which is the nerve of our stomach that's responsible for movement of the stomach and physical digestion of food, is damaged, as well as ghrelin, which is the hormone released by our stomach responsible for hunger sensation. The regulation of ghrelin is impacted. And so patients with gastroparesis often experience early satiety, abdominal pain and bloating, nausea, vomiting, malnutrition, and even death. Now, patients on insulin who have gastroparesis can have a lot of problems with this due to hypoglycemia and hyperglycemia. When a patient takes their insulin with a meal, the insulin starts working about 10 to 15 minutes after injection. Now, if the patient has a slowed or delayed emptying of the stomach contents, it'll take longer for that food to be digested, and so the insulin starts working, decreasing blood sugar levels, but the food isn't in your system yet. So just as the insulin's action starts wearing off, the food's being emptied from the stomach, and your blood sugar will increase, causing these large swings in glucose levels in patients with gastroparesis who are on insulin. According to the practice guidelines, when a patient comes in with these complications from gastroparesis, the nausea, vomiting, abdominal pain, it's important to provide the patient with antianemics, with motility drugs, manage their pain, and to correct fluid and electrolyte balances. And these were all done in the hospital. The patient was prescribed Zofran and ropinirole. The patient was prescribed metoclopramide, as well as acetaminophen, Percocet, tramadol were available as per the patient's request to manage his pain. And the patient was placed on IV fluids. He was given normal saline with potassium chloride at 125 milliliters per hour to correct any fluid and electrolyte imbalances. It's also important that in patients with diabetic gastroparesis, blood sugar levels should be corrected if necessary, and again, this was done. The patient's capillary blood sugar was checked regularly, and any hyperglycemia was corrected with insulin, as well as continuing the patient on his home regimen of metformin. And education on nutrition-related recommendations to lessen unpleasant side effects of gastroparesis was carried out at the hospital I was interning at, but at the previous hospital admissions, the patient stated that he never saw a dietitian and he was never educated on any type of nutrition intervention or diet or lifestyle changes that he could do to combat these symptoms. Another thing that my hospital did not do was to provide smaller frequent meals in chopped or liquid form instead of the 3 regular meals a day. The small frequent meals in the chopped or liquid form will help a patient with the emptying of a stomach. Typically it needs less digestion and less of that mobile digestion. But in the hospital I was at, the patient was placed on a regular diet. He was given a multivitamin to replace any nutrients as needed. He started eating better by the time I had seen him. But one of the practice guidelines is to initiate tube feeding if a patient experiences severe or significant unintentional weight loss, or if the patient experiences multiple hospitalizations from complications with gastroparesis requiring IV hydration. So the patient lost 75 pounds in 8 months, and he had also, including the visit where he was diagnosed with the gastroparesis back in January, this was his 5th hospital admission this year, and back in September, and there was no talk of initiating a tube feeding. He was again placed just on a regular diet. So my recommendations for future practice, first of all, is education. This was kind of a failure of the whole healthcare team at the other hospital at the time of his initial diagnosis. He had stated that he didn't even know what gastroparesis was, let alone anything he can do to prevent the unpleasant side effects. So it's important when a patient is newly diagnosed with any condition that he be educated on the condition and anything that he needs to know to prevent side effects from it. So that was very important, that I thought could have really helped this patient's overall care. And nutrition support would have been helpful. He was starting to eat better by the time I saw him, and he was actually being discharged the day I saw him. But even just discussing with the patient that there's a possibility of nutrition support, he was extremely worried. He was very depressed about all this weight loss and not knowing what to do, and kind of let down by doctors and the previous hospital that he had been in. So I feel that just knowing that even if right now he doesn't need a tube feeding, but down the road, if he continues to lose weight, or it gets to the point where he can't really eat at all without having these adverse symptoms or side effects, that there's an option that he doesn't have to worry about starving to death, and that he can really live with his condition and not fear it. So I think the education and the possibility of nutrition support is really important from patients with the diabetic gastroparesis. And these are my references that I used for my presentation. And thank you. I hope you learned a lot.